Our next presenter is Sue Cummings. Sue is a founding member of the Massachusetts General Hospital's Weight Center and the program manager and bariatric coordinator since its inception in 1998. Since retiring from MGH in 2017, Sue has been pursuing her passion for program development, teaching, and public speaking. Sue is the principal speaker in weight management for Catalyst, a training lab for dietitians in the Middle East, and has led training programs in Dubai, Beirut, and Jordan. Sue has been on faculty of CDR's Certificate in Training course in adult weight management for the past 10 years and is a developer and a facilitator in the new CDR course in obesity interventions. Sue is secretary of the American Society of Metabolic and Bariatric Surgery Integrated Health Executive Board. Whew. She is a plenary speaker at ASMBS Obesity Weekend in New York City next week and is the director of the ASMBS Nutrition Courses 1 and 2 during Obesity Week in November. Sue will be traveling to Australia in September as an invited keynote speaker at the Australian and New Zealand Metabolic and Bariatric Surgery Association and to Anchorage, Alaska in October to speak at the Alaska Native Tribal Health Consortium Diabetes Conference on Bariatric Surgery and Diabetes. Please welcome Sue.
Thank you. Is this too loud? Does this sound too loud? It's okay? I'm a loudspeaker, so we don't want them, they could probably hear me in Boston. Anyways, it's so nice to be here. My slides are not in your packet, but I will give them a PDF of my slides if you would like to have them afterward. So I was asked to speak today on nutrition complications and weight regain. I can tell you now that most of the conferences that I've been to, including Obesity Week, ASMBS Weekend, etc., the big hot topic is weight regain. Everybody's kind of like, what do we do about this? And so we're gonna spend a little time on that. But before I give any talk, I'd like to start out with some starting principles and get us all on the same page. And one is the recognition that obesity is a chronic disease. It's biopsychosocially complex. And so both in its origin and in its complications. And so it's very clinically diverse in presentation, and the reason why that's so important is recognizing that if we walk away with no message today, recognizing that obesity is heterogenetic disease, and because of its heterogeneity, it's difficult to treat. We haven't really found out, we don't really have the right answer. Susceptibility also is associated with very varying risks, and that each person, from one person to the next, has various predispositions to obesity in the same environment. So this is why we see people in the same family. One person may have obesity, whereas the rest of the family doesn't. And again, I think we're all now, after the 60s and 70s and 80s and 90s, where we were treating obesity primarily with diet and exercise, recognizing that it's much more the etiology of obesity is much more complex than we ever thought. It's going to be interesting today because I've had a really hard day with word retrieval. So I might be up here going, what was that I was trying to say? So body energy stores, and this is something that I get a lot of questions about, but really we all need to have this information, know this information. Set point is no longer a theory. Set point is basically our body's defense for a certain amount of body fat or adipose tissue. So body energy stores is maintained basically at a set level, and this is through a very complex weight regulatory system. And for all of us who are in the field of obesity, we need to have a better understanding of that. We don't have all of the answers, but we clearly know that our body is defending a certain weight. And it's not really a weight, it's a range of how much adipose tissue we're programmed to store. You can think about it it as a thermostat. In our hypothalamus, which is the weight regulatory system in our body, think of it as having a thermostat. So let's say we put this room on temperature on 70, and we're all pretty comfortable at 70, right? And let's say there was a blizzard, because it is New England, outside, and we opened up all of the windows, and that ice cold air came in. The thermostat is set at 70, this ice cold air comes in. What does the thermostat do? It tells the generator, the heater, the furnace, to work harder. It's set at 70, the temperature drops here, the thermostat tells the furnace work harder and harder to get back up to 70. So you can think about weight regulation in those terms. We have a thermostat in our hypothalamus that's set at a certain range of adipose tissue storage that the body defends. And so when weight goes below a certain thermostat setting, the body fights back to get back to that setting. Does that make sense? So deviations from this setting, or this preferred set level, are resisted and minimized by a very complex feedback control system. And why it's important to understand this is because if we understand some of those mechanisms, then we understand when certain treatments are indicated, whether it be pharmacotherapy or bariatric surgery or whatever other treatments are coming down the pike. And so defense against starvations, our bodies seek a stable adipose tissue mass, not unlike body temperature or blood volume. We don't get up every day and wonder, do we gonna have enough blood volume today, right? Our bodies regulate that very fine-tunedly. And adipose tissue is regulated in the same type of system. So therefore, diet-induced weight loss is accompanied by physiological adaptations. So this is why there are many of our friends and family and society, people in society, that tell us, I don't eat that much, or I do eat less, I am exercising more, and yet they get stuck at a certain weight. Or as soon as they get to that lower weight, their body starts making them hungrier, the metabolism drops, and it's much more of a struggle for them. And so when we add physiology, we recognize it's more than just calories in and calories out. Now, the GI tract is the largest endocrine organ in the body, right? And so there's gut messengers, right? And these are the messengers we want to get familiar with, because this is where most interventions for obesity treatment are targeting. So we have ghrelin in the stomach that's produced by the stomach, ghrelin being the only orexigenic hormone in the digestive tract. And then we have all types of hormones being released by the duodenum and the jejunum and the lower colon that work on hunger inhibition. We have gut microbiota, I'm going to talk a little bit about, because that's another fascinating area of research. We have the vagus nerve, and all of these messengers from the GI tract are talking to the hypothalamus, which is then regulating hunger and satiety. So I would get familiar with these major players here, because this is where either pharmacotherapy is targeted, definitely bariatric surgery is targeting, and new devices coming down the pike are targeting. And these are the major players in the GI tract, and you may already know that. And I've given you some really nice references, a couple of papers in your reference list on the hormonal regulation of body weight that I think are two of the most understandable. You might have to read them a few times, but so what this here is showing, this is one of the papers that I gave you, and this is just showing when, and this was mice studies, when these mice were put on a diet over a certain amount of time. After the diet, you start ghrelin going up, meaning they're getting hungrier, ghrelin going up, they're getting hungrier, and then PYY, amylin, some of these other hormones going down, which means they have less satiety. And this is just showing the adaptation to restricted intake and the body trying to hold on to adipose tissue. So the struggle is real. That's my emoji. I need to give her a summer hat. Okay, so the struggle is real. And The bariatric surgery, and we're all bariatric specialists in this room, so we all know this. This is basically just my starting principles, getting us all on the same page. By manipulating the gastrointestinal tract, we're altering these gut hormones and these players in the weight regulatory system. And we're doing it in different ways, depending on which bariatric procedure. How many of you are working with surgeons that are doing the sleeve? Who's not doing the sleeve these days? Bypass? So bypass and sleeve. How about the biliopancreatic diversion, duodenal switch? I actually don't think there are any surgeons in New England area that, or at least I know not in Massachusetts, that are doing biliopancreatic diversion with or without the switch. And that's primarily because it does, even though it's the most effective as far as diabetes and weight control, it also carries with it higher risks. So by manipulating the intestinal tract, we're influencing gut hormones, neural messaging, and gut microbiota. And therefore, what we're doing is, not us, because we're not in the OR, but what bariatric surgery is doing is changing the set point. And any intervention, any effective intervention for obesity needs to change the set point. That's what we're looking to do, to change that set point. Can you change the somebody's set point through lifestyle interventions, diet and exercise, let's say, alone? You actually can. So you can change set point. Somebody can maybe have a set point. Let's say their BMI range is, 38 to 45, and when they get up past 45, they can lose weight pretty easily, but once they try to get below 38, their body's fighting back. You can change that set point lower through diet and exercise. The issue is, whatever you do to lose the weight, you have to keep doing over years to have that influence on set point. And you can do it also with pharmacotherapy. Another effective intervention, not as effective as bariatric surgery, is changes set point. Okay, so basically, and this is just another mouse study. This was actually in Dr. Kaplan's lab down at MGH, looking at this was not from Dr. Kaplan's lab, I lie. Take credit, but I'm sorry, this is a different study. But this is basically showing hormonal changes after doing bariatric surgery on mice, which he has done in his lab. And what you see here is you see a drop in ghrelin, so less hunger, and an increase in the satiating hormones like PYY, amylin, and GLP-1. So ghrelin, we already know, we've talked about orexigenic hormone. And so that has a big influence. The sleeve primarily has an influence on ghrelin because you're taking out 80% of the stomach, give or take, and you're taking out the fundus, which is the primary production site of ghrelin. Body still makes ghrelin, but you're significantly reducing hunger. So that's one of the mechanisms of the sleeve. And with the bypass, the studies, this is going backward. The bypass, the studies are very variable. In 1999, when David Cummings, he's now no relation, came out with a paper and said he studied individuals who were matched for diet intervention and bariatric surgery intervention. And what he saw in that study, what they observed was there was a significant decrease in ghrelin. And so his paper was one of the mechanism for Roux-en-Y gastric bypass is decreasing ghrelin, when in fact that couldn't be reproducible. There are studies that show there is no decrease in ghrelin. But actually what's happening is when you transect the vagal nerve, so right in the bypass, you're transecting the vagal nerve, they're cutting right across that. That transection, even when ghrelin is produced, reduces the hunger signal of ghrelin. So ghrelin is definitely, or changing or doing something to the stomach, is definitely influencing the weight regulatory system. Did you get that? Look at the slide real close, because I want to make sure you got that, because I work hard on these movements. Watch the stomach. Got it? So basically, it's the acceleration of the food leaving the new pouch now into the jejunum, right? We bypassed the duodenum, right directly into this accelerated nutrients, food going right directly into the jejunum is what's responsible for the significant increase in those hormones that inhibit gastric emptying, inhibit appetite, and increase satiety. There's also favorable changes done in the microbiome after both the sleeve and the bypass that I'll talk about. Now, we do see food going a little faster into the intestinal tract after the sleeve just because there's less volume, so food has to leave the stomach a little faster. We don't have as much of a profound effect with the sleeve as we do with the bypass, which is probably one of the main reasons we see a little less weight loss as well with the sleeve, although that's becoming debatable. So basically, weight loss after a bariatric procedure has almost the exact opposite effects as weight loss through dieting, and it has to do with the influence of these hormones that influence the adipose tissue set point. So that's sort of getting us all on the same page. So when I do an assessment with a patient, whether it's before surgery or not even for surgery or after surgery with weight regain, the questions I'm asking is to get at primarily what's going on here. What are some of the mechanisms that might be driving the hunger or decreasing the satiety? And then what are some of the nutrition strategies that we can use? So despite the profound effects of bariatric surgery on energy balance, on this set point, outcomes still vary, right? We still see varying outcomes. As much as our patients all want to lose the same amount of weight, and why is she losing more than me and he losing, more than anybody? It's because we have a heterogenetic disease that we're treating, and this heterogeneity is going to show itself even in outcomes after interventions. Okay. Most patients, as we all know, don't lose 100% of their weight. So it's really important for us to manage expectations. I get a little crazy in our clinic when I hear another provider saying, well, you should be losing this much by now. The graphs show that, this is the amount of weight loss you should use. We shouldn't should on anybody to begin with. Should's a really bad word in that sense, but there's too much variability to set up those types of expectations. And I think a large part of why patients may not come back for follow-up, especially if they've had some weight regain, is because they feel they shouldn't have gained that weight. So we need to be very, very careful about managing weight loss expectations and sharing that it's very variable. Having said that, what's the data show so far? Anybody still doing the band? You still putting in the band? Okay, more bands are being taken out in this country now than are being put in. We've actually exceeded the number being taken out that are being put in. And that's primarily because the long-term outcomes were not very good as far as weight loss, comorbidities, and because of the complications that come along with keeping a band in too long. We don't have 10-year data yet for the sleeve. We have, random papers here and there, but we really do not have good, solid, randomized controlled trials looking at 10 years out for the sleeve yet. I was hoping we'd get it at Obesity Week last year, but we didn't. Maybe this year that data will be there. And then with the bypass, of course, we do have long-term data. So the other thing, and I'm sure you're familiar with it because you're all specialists in bariatrics, but there's a difference between how the medical literature reports weight loss and how the surgical literature reports it. The surgical literature reports it in percent excess weight loss. Drives me nuts. Half the time I'm like, how do you figure that out again? And I think that's changing over time. But the medical literature and what most of our patients will understand better is percent weight loss of your initial weight. Percent initial. So in parentheses here, I put what excess weight loss would be. And it's usually twice as much. Or if you look at reading a surgical paper and says 70% excess weight loss, that's typically about 35% initial weight loss. Okay, but every bariatric procedure study demonstrates this wide variation. Everyone, if we look at the bypass, the sleeve, you see the same shape curve. So managing weight loss expectations, we really don't want to use these curves or this data as predictors. It's information, it puts us in the ballpark, it helps with our assessment, but we have to be really careful using these numbers to predict what each individual will lose, because we don't know. Now, if we look at bariatric surgery by the numbers, we did our first surgery at Mass General Hospital in 1999. And then, what was the standard procedure? The Roux-en-Y gastric bypass. And even as, in 2011, 37% of the procedures being done were the bypass. About 18% were the sleeve. And look at how many bands were being done. I remember when the band was approved in 2001, and everybody was jumping on, forgive me for this, but the bandwagon. Patients were like, hey, I want you to give me that band. I don't want anybody cutting up my insides. If I want to get pregnant, I can, not fill it. If I want to go on a cruise, I can take it out. But bottom line is there's actually more complications over time with the band, because when it has to be taken out and you're doing a second procedure, a revision procedure, or doing another surgery, a second surgery, always imposes higher risks. But look at today, 2016. About 19% of the procedures done in the US are the bypass, and 58% are the sleeve. So now there's more and more sleeves being performed. And why is that? Why would you think that is? Less risk is primarily the reason that most surgeons will give, or most patients say, well, at least you're doing a little less surgery. I'm not sure about that. Okay, so this, I already said this. Now, which procedure? How do your surgeons make decisions on which procedure? He only does the sleeve. And typically that's what's gonna happen. In most cases, if you have a surgeon who only does a band, what do you think you're gonna get if you go there, right? Or the sleeve or the bypass. And that's typically what's happening. And the main reason being is we don't really have good predictors of what's the best procedure per person, for each individual person. Okay, there's no empirical data to guide surgeons or any other health professionals on matching patients to procedure right now. However, and I put these two studies in your reference list with just a little summary of each, but two recent studies, they're both 5-year studies. One is completed, we only have 3-year data so far. But these are randomized clinical trials that compare the bypass and the sleeve. The Swiss multi-center bypass and the sleeve study, SM-BOSS study. And these two studies are looking specifically at long-term, what's the outcome in comparing sleeve and bypass. Okay, so these are important contributions to the literature, because having that information, having some type of information that can help us match the patient to the treatment is ideal in any situation. Eventually, we're gonna have genetics to do that. Eventually, there's gonna be genetic tests. We already know from my studies that there is a certain genetic coding that tells certain, that actually can predict which mice will do better with the bypass. So I think we're getting there, and we will be there, but we're not there yet. I mean, eventually we'll have that genetic coding for diets. Is this person going to do better on a higher protein or a higher carbohydrate? But we're not there yet to do that. So these are important to look at the long-term data and make the comparisons and see if we can, through a thorough assessment, determine what might be a better procedure for a person. Complications are the main reason before you do any type of intervention, pharmacotherapy, diet, bariatric surgery, you always want to do risk-benefit. And basically, GERD seems to be the highest risk associated with the sleeve gastrectomy. Cholecystectomy, pretty much across the board even. And any type of rapid weight loss you're at risk for a cholecystectomy. The two risks that are associated with the bypass, which makes the bypass a little more risky, is the small bowel obstruction that can occur because you're doing surgery on the intestines. So you have surgical spots there where scar tissue can build up and get an obstruction, and internal hernias. Insufficient weight loss is more common with the sleeve than with the bypass. So patients should be informed that making this decision is very complex, but they really should be thinking about, which procedure with risk versus benefit for that individual. Okay. Okay, so the bypass is always quoted as, and this is where a lot of controversy is. I don't know how many of you are on tweets with a lot of these surgeons, or you hear this in conversations, but there's two parties, sleeve over bypass, which is why these studies are so important to have. And typically we report that, if you have severe diabetes, you definitely want to consider the bypass. It's actually being considered as a procedure intervention for diabetes, so that patients who have a BMI of less than 35 with uncontrolled diabetes can have the procedure. The study you want to look at there is the STAMPEDE study. If you're not familiar with Dr. Schauer's 5-year randomized control trial looking at medical intervention versus sleeve versus bypass, these are the real numbers. This is, a randomized control trial. The numbers are real. They're not the 80% of people are cured from diabetes. We're not necessarily curing people from diabetes. It's chronic. But his data show the difference between the sleeve and the bypass and what those numbers are. Okay, but if you have a patient with GERD, with severe GERD, gastroesophageal reflux disease, you really want to think twice about the sleeve gastrectomy. It's not totally contraindicated, but it may be a contraindication, and Barrett's esophagus is definitely a contraindication. Okay, we say, well, the sleeve is low risk, but so far in the studies, there's really no difference in the reoperation rate between the sleeve and the bypass. Okay, so discussion needs to be done, and really it's down to what's the acceptable risk to the patient. What risk are they willing to take on? But we need the 10-year studies, and they're coming. Okay. Now, there are a certain amount of patients. How many of you have seen patients who have lost less than 20% weight loss? Okay, so what's going on there? So that's called inadequate weight loss. It's defined as inadequate weight loss, those people who are sort of at that end of the spectrum. And it's defined as a failure to lose a significant amount of weight. So what you would expect to see, weight loss that you might expect to see. And it's usually less than 20% of their initial weight that they've lost. Inadequate weight loss is really a biological event. So basically what I mean by that is we did very early on in our clinic, we did a study and looked at who are these people. And basically what we found was patients who came in wheelchairs, who may have amputations, who have been immobile for years, did not do as well. And so the reason for identifying this as a biological event is to understand this isn't the patient not adhering to what we're saying or recommending. Okay, it's not always predictable. We can't always predict who that's going to be. We have to really do a very careful assessment and then kind of vary our approaches. We really want to aim at treating the set point. So is there any lifestyle interventions that we can make that may help there, whether it's metabolism or diet? Most often, it requires a conversion surgery. So what you'll see is maybe the sleeve being converted to a bypass, or the band being converted to a sleeve or a bypass. But this is also a time that pharmacotherapy may be considered. So looking at weight loss medication, combining that. Combination therapy is really the wave of the future. What we're seeing is combining, whether that's lifestyle plus surgery, or lifestyle plus pharmacotherapy, or lifestyle plus pharmacotherapy plus surgery. But these may be candidates for that. Okay. But even in patients who have had significant weight loss might see weight regain. These are fat cells just saying, want to go back. And I think, again, as I said when I started out, this is one of the biggest challenges in the field right now. What's going on, and what do we do when somebody's already had surgery and they've gained a significant amount of weight? Well, we should expect that, and we should be talking to we really need to be talking to patients before surgery and managing their expectations that it is most likely they'll see weight gain over the course of maybe the next 10 years. And what we see, and this is a Swedish obesity study that went out 10 years, most of the weight loss occurs in the first 18 months, and then from 2 to 5 years, you see this weight regain. And in fact, about 15 to 25% of the lost weight is regained over a period of 10 years. Again, this isn't a prediction. It's very variable from person to person, but patients need to understand that there may be some weight regain. And by setting these expectations, as nervous as it makes a patient, at least afterward, when they start seeing this, if they start seeing this, they feel safe to come back. They know this was expected. They're not embarrassed to come back. They know, that this might be something they need a little extra help with. So I wanted to introduce you to a patient. This is Ira. Okay, so in 2003, Ira weighed 495 pounds. He had a body mass index of 67. He had gastric bypass in 2004, and he lost 185 pounds, 37% of his initial weight, 75% of excess weight. He was down to 310 pounds. He still had a BMI of 42, which if he went to his PCP, who didn't know he had bypass, or anyone else, till tell him, to lose weight, but he did very well with the bypass. He was down to a BMI of 42. And then 4 years later, he gained 54 pounds. Over the course of 4 years, he regained 54 pounds. So this was his food recall when he came in. He skipped breakfast. This was 4 years after his bypass. He ate lunch like 11 o'clock, the cafeteria was open. He was there for lunch because he was starving. He hadn't eaten, he got into work early, he was really hungry. He'd get a hot meal, and then about 4 o'clock, he'd grab a granola bar because he was getting hungry again, but he didn't have time, so he just grabbed something fast from the vending machine. And then at 5:30, he started to get really shaky. One afternoon, he fainted at work. He usually grabs a juice to feel better. So this was going on in the last couple of years before he came in. Was he experiencing dumping at 5:30 in the afternoon or hypoglycemia? Hypoglycemia, right? And that's hypoglycemia. Reactive hypoglycemia commonly occurs about 2 to 4 years. You start seeing it after the bypass typically. So it's something that might occur in your later post-op patients. And it is a trigger for weight regain. And so the ASMBS has two definitions. They call one early dumping and one late dumping, which I wish they would just change. I think I have to get in there and talk to somebody. But early dumping is what we think of as dumping syndrome, okay, where food dumps fast, typically maybe a carbohydrate or a sweet, and there's symptoms. Late dumping recurs a few hours after, and this is basically reactive hypoglycemia. And I'm always amazed that dietitians, when I'm teaching in the CDR course, dietitians that are non-bariatric dietitians are always like, what do I do? The patient had bypass and they're having these symptoms. Treat them like every other patient. Treat them exactly. And as a matter of fact, we need our specialties, especially pre-surgery and early post-surgery, but most patients, as they get further out from surgery, can be treated by other dietitians, knowing that bariatric surgery patients, the only difference really is their micronutrients. But in general, from a weight regain perspective, we would treat them exactly the same. The same thing with reactive hypoglycemia, which is caused by you have this food, watch the food, leaves the stomach, boom, dumps into the jejunum, causing this exaggerated insulin response. And again, remember, the jejunum is where GLP-1, GIP is released. So an excess release of this causes an excess release of insulin, and therefore reactive hypoglycemia. Possible additional causes might not just be food, though, and we might have all seen this in our practices. Beta cell hyperfunction, so there's excessive insulin being created. Patients might have had an underlying familial hyperinsulinemia syndrome that was unmasked by the weight loss. In other words, as they were overweight, eating in response to all this insulin, not even realize they're doing that, maybe even contributing to the obesity. Now they've lost this weight and they have this excess insulin being secreted. Or increased beta cell mass, which also can develop during obesity and not regress. So we treat it just like all dietitians learn in undergrad. You treat it just like you would any other reactive hypoglycemia, small meals, a protein source at each meal, not skipping meals like Ira was doing, grabbing a granola bar, which of course is healthy, at 5:30 instead of a meal. Okay. But also we want to be thinking of protein. How many of you are sick of protein? It's like crazy, right? I've shared this before. Did you ever go down the cereal aisle? Okay, you go down the cereal aisle and there's Cheerios, right? Good old-fashioned oat Cheerios. And right next to it is the exact same box of Cheerios, but it has this big stamp on it. It says protein. Like right above Cheerios, protein. So our patients go down there. Which one do you think they're going to pick? Wow, Cheerios has protein. Let's get that. That box with protein in it has 17 grams of sugar for each half cup serving. Original Cheerios has 1 gram of sugar that occurs naturally. I mean, it's crazy, this protein phase. And I feel like being in bariatrics, it's harder. Because we're talking early on, we're talking about getting in essential nutrients. Essentially, your body doesn't make this, you're not eating or drinking very much, you gotta eat this and drink this to get those essential nutrients in. That gets so confused with the whole marketing out there because we worship certain nutrients every decade and we demonize others. I was in the store the other day and I heard this teenager say to his mom, "Mom, let's get some sweet potatoes." She goes, "Oh, we're not eating potatoes anymore, they have carbs." And so we're demonizing and we're worshiping and now we're talking about a procedure and healing from a surgery and we're focusing on amino acids and we're calling it protein, but they're getting all confused. Anyway. That's a soapbox I can go on. But protein, obviously, for treating hypoglycemia, it enhances glycemic control. Also, by having a small source of protein throughout the day, it suppresses ghrelin the most. And so avoids excess hunger. Okay, and this is a study showing that if you add a protein source to a meal, that you will see a longer time. Ghrelin typically is released every 3-4 hours from the stomach, telling the brain, hey, we need some food. It's a survival mechanism, but protein will suppress that longer. So if you have somebody who has, say, I can't eat for 5 or 6 hours, make sure the meal they're eating before that 5-hour break has protein in it. And we'll do the same for our hypoglycemic patients. If there's a lack of diet response to hypoglycemia, reactive hypoglycemia, then medications is the next level of choice. And there are medications that delay the breakdown of starch or delay gastric emptying or slow down the release of insulin from the pancreas. And so these patients, if you're working with a patient that's not getting response from our diet intervention, they definitely want to be referred back to their doctor. But if that doesn't work, then they need to see an endocrinologist. Nocidioblastosis is a phenomenon of excessive insulin secretion. Typically, too much beta cells may have been created after a bypass. It's not very common, but it occurs, and it typically requires a pancreas surgery. So reactive hypoglycemia, we can confirm it through laboratory tests. Try the diet measures 3 or 4 weeks. If that's not working, medications. And then if that's a lack of response there, we want to be referring on to an endocrinology. I had a patient who knocked out 2 teeth with his hypoglycemia before he was willing to actually go see an endocrinologist. We did diet, we did medication, no intervention. So with Ira, we were assessing his weight gain. But he said he still gets full. So we looked, we found he had a little hypoglycemia, reactive hypoglycemia. His meal planning was not ideal, worked on that. And then he did say, I get full pretty easily. What does that tell you? He had surgery at this point 4 or 5 years ago, and he still gets full easy. What that tells me is his surgery is still working. His bypass is still working. However, it's very important as we assess causes for weight regain that we assess are there anatomical issues going on. Before Let's see, what was it? When did laparoscopic become more common? Probably the early 2000s. So I know when we first started doing bypass, it was the open procedure. And procedures, so if you have patients you're seeing that had surgery in the 90s, early 2000 or 80s, these patients had an open procedure. The difference between an open procedure and the laparoscopic in technique is with the open procedure, they did not separate the new pouch from the old stomach. They just stapled it off. They just divided it. So you may have a patient who's experiencing staple line breakdown and literally using their old stomach, which we've seen not uncommonly over the course of our 18 years. So a patient should always be assessed with the bypass. Is there a fistula? Pouch enlargement is rarely a reason for significant weight regain. And also the anastomosis dilation. Dr. Chris Thompson has done a lot of work over at Brigham doing things like sclerosis, did I say that right? Where he's like scarring the anastomosis to try to build up a little more tissue and narrow the opening. It really hasn't been that favorable in producing more weight loss. And then, of course, with the band, always assess, is the band even, is there problems with the band? Okay. We also want to assess clinical features and behavioral features. Our patients, including Ira, have continued exposure to this environment. Their bodies have changed, the environment has not. And so what I'm going to show you now is what I'm going to call lifestyle influences that are amenable to change or that are modifiable. So what are the things when we see a patient with weight regain we want to key right into from a lifestyle perspective? What's going on that might be increasing weight? Processed diets, irregular eating patterns. Notice I don't have calories written there. Inadequate physical activity, inadequate sleep, lots of data on lack of sleep, less than 7 hours a night sleep and weight promotion, and I'll talk about that when we talk about circadian rhythm. Stress, weight increasing medications, and then also recognizing when a patient comes back with weight regain, if they've been through menopause or if they've had a number of pregnancies and they didn't lose the weight from one pregnancy to the next, these are vulnerable times of weight gain, right? We call them developmental stages. So there's various times in our life cycle where we're vulnerable to making more fat cells, not just filling up the fat cells we have, but making more. And that would be early childhood, adolescence, pregnancy, menopause, and aging. So probably 99% of the time, this is probably the first thing that I might notice with a patient that comes in with weight regain. They just have chaotic eating patterns. Life's gotten too busy. It's 2 years after surgery. No one's telling them I look great anymore. Not buying new clothes. Forgot what it was like to take the medication. Life starts taking over. The family, the friends, the job, and they're skipping meals, grabbing things like Ira. This was one of the things that happened to him. Okay. When combating the effects of chronic disease, food timing has emerged as a new approach to treatment. So what I'm saying here is the timing of a meal versus calories at this point, right, are being looked at very closely. Lots of studies for obesity and metabolic syndrome. And regular eating habits or eating patterns may be significant in managing energy balance. So unplanned snacking, which is what we saw with Ira, as well as consuming a major part of calories in the late evening, especially in the dark late evening, may be very unfavorable. So what we might see is disrupted eating patterns leading to irregular meals and frequency of meals and clock time meaning, are you eating at midnight, disrupts the internal clock, which then may disrupt energy balance and metabolic function, causing metabolic dysfunction. So really focusing on maybe the first time you see somebody come in and you're seeing these kinds of meal patterns, thinking about, well, let's talk about how we can structure your eating during the day. By doing this, you're avoiding overhunger. You're helping the patient focus a little more on the planning and preparation that basically has to occur. You're helping them build success into their environment, avoiding that hypoglycemia, creating satiety, regular meal patterns, there's better satiety. And it feels a lot less like dieting than saying, well, let's just get your calories down. Okay. The other thing we know is that disruption of the circadian clock by genetic or by environmental factors precipitate a number of disorders, including obesity. So our circadian clock, meaning there's certain hormones that are released in that 24-hour cycle, is important to take note of. And who do you think about when you think about the circadian clock? What type of patients? Yeah. So multiple genes and hormones that are involved in energy regulation and nutrient metabolism have rhythmic cycles. So as somebody just said, shift workers. If you have somebody who is a shift worker and they've had those hours for years, that's most likely contributing to their obesity. Okay, so these can be policemen, airline personnel, healthcare providers, nurses who work those shifts. Because what happens is later in the evening, during those night hours, there's an increase in ghrelin. What does that mean? They're hungrier. Increase in cortisol, hungrier and looking for highly palatable foods. Decrease in leptin. Do you know, we didn't even know what leptin was in the 80s. When I think of when I was practicing in the 80s, it was all about writing the perfect diet. We didn't even know leptin. But when you think about leptin as the gas gauge. When leptin is high, the brain thinks, okay, we got enough fat on board, our fat cells are full. When leptin is low, hypothalamus goes, oh, we're not getting a lot of leptin signals, must need more adipose tissue, must make you hungrier, burn less calories, let's store that fat. So if we're eating in the evening hours, or awake during the evening hours, there's increased appetite. Also, what we know is that we know diet-induced thermogenesis, right? It's not very large percentage of the calories we burn in a day. 10, maybe 15% of the calories we burn in a day. But that 10 or 15% is lower in the circadian evening. So people who are eating during that graveyard shift are burning less calories, even digesting their food. Now that doesn't mean much maybe in the course of 6 months or a year even. But over years of this type of behavior, it can be significant contribution to weight gain. So what would you do for somebody who works shift hours if they can't change their job? From a nutrition perspective, I'm thinking, okay, ghrelin is suppressed by protein. I'm gonna help them eat during the evening, but the foods they eat, I'm gonna refocus on, right? And protein also has a higher thermogenic effect. But I'm not jumping on the protein worship thing here. I'm talking about it from a perspective of how to manage hunger and satiety. So shift worker, higher diet-induced thermogenesis, I'd consider that in their planning. Now what about stress? There's detrimental effects of stress, and this isn't the big stressors. Somebody dies, somebody got divorced, you lose a job. These are the daily. Like, I'm so happy that I retired last year because I don't have that hour and a half to work commute and hour and a half home, or it's just like distress, right? 3 hours a day like this. What does that do? Well, it can increase binge eating. It's attributed with skipping meal patterns, and it's also associated with the increased desire for highly palatable food, salt, sugar, fat. So what we know about stress, that distress leads to cortisol, which leads to insulin resistance and hyperinsulinemia, which leads to leptin resistance. Remember, leptin is telling the brain whether we have enough fat on board, which causes a decrease in metabolic rate, increase in food intake, and an increase in these very highly caloric, palatable foods. So what do we do then? I would recommend, we can address eating patterns. We know that. We're good at that. This is what we do. But we might want to address some of the lifestyle barriers. It always amazed me at our center where we have an interdisciplinary group or a multidisciplinary group, that everyone goes to the dietitian. And sometimes I'm like, psychologist, if you could work with them a little bit on the stress management, which is a big issue, then we could work better on the nutritional issues. And so providing patients with the tools and techniques teaching them how to de-stress, how to manage that stress, whether it's you know of a program that does relaxation response, or you have a psychologist, or maybe you yourself are good at that, helping learn techniques to kind of elicit before that cortisol gets shooting out there. He looks pretty comfy to me. Okay, now what about diet quality? So I just did a whole data review for talks I'm giving in Obesity Weekend next week in New York City, and I was looking at the data. Okay, what are the contributions to weight regain? And so, diet quality. When I looked at the nutrition literature, the two things that came out were diet quality and follow-up with the nutritionist, follow-up visits. Those were the two things highly related to weight regain. Now, when we think about diet quality, we're not thinking, again, about calories, then that makes me think of gut microbiota. And I know right now it's a hot topic. So I don't want you to think I drank the Kool-Aid, the microbiota Kool-Aid. But how can we use this data, this information, to help us when we're planning diets for people, when we're helping people with their nutritional intake? So gut microbiome plays a very important role in energy balance, okay, and also in the development of obesity and the progression of obesity and type 2 diabetes. It's a fascinating field. You guys keeping up with this? It's really fascinating. Gut microbiome, the ecology of gut microbiome, differs between lean individuals and individuals with obesity. And so what we see here is individuals with obesity have a much higher level of Firmicutes, which is a very unfavorable type of microbiome, which contributes to decreased satiety, decreased fullness, increased lipogenesis, increased inflammation, which is associated with metabolic disorders and obesity, decreased fatty acid oxidation, versus a lean person who has a higher level of, should I try it? Bacteroidales. I always say F's and B's, but a higher level of a more favorable microbiome. And so this may be one of the contributing factors, again, to obesity, and not in everybody. The microbiome, from what I understand, when you look at international cultures and how they eat different, there is definitely a genetic variable to this. The bypass and the sleeve both change microbiota, and this is independent, just like the diabetes, it's independent of weight loss. And so the altered microbiome, the unfavorable microbiome becomes less and the favorable becomes more. And this influences body weight and adiposity, lipids, and insulin. So what we see after a bypass and a sleeve is there's a higher level of favorable microbiome, more like a lean person in our patients with obesity. Now we combine that with knowing that our diet accounts for about 57% variation in microbiota. And we combine that knowing that the typical American diet, the processed red meats, the sugary desserts and drinks, high-fat foods, low fiber, are associated with the F's, the unfavorable, and a decrease in the favorable. So we also know that every food, when you look at a label and you see polysorbate, methylcellulose 80, those are emulsifiers. And there's very strong evidence emulsifiers influence microbiome in a negative way. So if you have somebody who's eating a diet that's 80% refined, processed, and 20% will have a salad here and there, that's a good place to go. It's a good place to go, to look at the quality of food. And so a healthier diet with prebiotics, and if you're comfortable recommending probiotics, can work with that favorable change that's caused by a sleeve and a bypass surgery. Does that make sense? Okay. So, oops. Oh, my picture came on top. Anyway, we all know what probiotics are. This is just probiotics eating up all that bad bacteria. But prebiotics, now I don't know how comfortable you are recommending probiotics. I just had that discussion with Steve out here from Bariatric Advantage, because they have a probiotic that I actually started taking and I like it, only because I got a free sample. But how do you recommend probiotics? I mean, it's very complicated, right? We don't have any really good guidance for us as dietitians saying this is the probiotic you need, and if you buy this, it's actually going to have in it what the label says, because it's not legislated. However, we decided, and I asked Dr. Kaplan, who's a GI doc too, the same question, like, what do you know, how do you make these decisions? And he goes, I would just say, let them take it, and if they feel good and it's working, then it's working for them. If you need to really, if you don't really understand probiotics, it's hard for us to make a specific recommendation. But prebiotics naturally occur in food. And so again, a higher quality diet full of all of these foods that contain prebiotics will actually promote probiotics in the gut. So these are ways we can work with some of the favorable changes after bariatric surgery without focusing on calories. Okay. Our diet's been hijacked. I had a patient in one of my post-op classes say to me, oh my gosh, I finally got my kids to eat vegetables. And I'm like, wow, it's terrific, how'd you do it? And she goes, well, I found these veggie noodles. You can get as much tomato as if you lick the tomato, right? The nutrients from the veggie noodle that says it's the color of tomato. So of course, we all know this, lots of misinformation out there. Our diets have been hijacked. Cheerios, just think of that. And so helping patients think more of moving toward a healthier quality diet and maybe not so much focused on calories. Okay, so what we want to do is address environmental triggers to weight regain, stress management, sleep hygiene, very important, chaotic meal structures. Remember that individualized diets are the most important. We will never be out of a job because there is no one diet for everybody. And so we need to work with patients, assess, and match the right treatment. Diets are a therapy just as surgery is, and matching the patient to the right treatment. And it needs to be individualized. But focusing on real food versus food-like substances that many of our patients are eating would be helpful. And then not high protein, but protein maybe at every meal and snack, or at least at each meal to sustain that glycemic control. Okay, also Ira said he was feeling really tired all the time, and he was prescribed Paxil for depression. If you see somebody with weight regain who's on Paxil, what do you think? It's contributing. So I hope all of you have a list or that little food interaction book at your desks to look up, when you're assessing patients, to look up their medications and see if it has a strong weight promoting effect. There's many antidepressants that are weight promoting. There's endocrine agents. There's miscellaneous. How many patients do you have on metoprolol, which can be weight promoting? And so if you don't have these lists, you can email me. I have somewhere in my files, if I haven't lost them, lists of these. Or you can get that nutrient interaction book, look up a med, and it'll tell you if it's weight promoting. But this is something when you do an assessment, you want to look at every medication and see if they're weight promoting. Because some of our patients literally are gaining 30, 40, 50 or more pounds on some of their medications. What would you do then? You would call the providing prescriber, see if there's an alternative, or you can talk to their primary care or their provider that's making these prescriptions and think about maybe adding a weight loss medication that would take away the effect, the weight promoting effect. Okay, so we did talk to Ira's PCP. Paxil was changed to Zoloft and also Wellbutrin. We started seeing him, follow up again, really important. We started seeing him initially every other week, and then we moved out to once a month. He lost 45 pounds of the 54 pounds he gained, so he was able to lose that and maintain it. You know, meal structure, types of food, and then he said he hadn't had his nutrition labs done in 2 years. Is that any surprise? He hasn't been back to his center. And we know that this is a combination of the ASMBS paper that was published in 2017, but it's the 2016 micronutrient updates, and also Dr. Stein's papers. So these are just looking at, the light gray line is pre-surgery deficiencies, and then the red is post-surgery deficiencies that have been seen. And so have you all read the 2016 update, the ASMBS nutrition update, have it in your files? It's really important because biochemical surveillance typically, as we all know, begins 2 or 3 months. Some deficiencies manifest fast, some take years. How often do your patients come back every year? For the rest of their lives? We did our first surgery in 1998. I can tell you now, those thousands of patients that we have done surgery on are not coming back every year. And so it's really, really a big issue, the long-term monitoring. When you see a patient though, if you suspect or if they have like a low level, lab level of a micronutrient, but you suspect there may be a deficiency, really combine signs and symptoms with your lab tests. How many of you do nutrition-focused physical exams? You can get training in this, specialized training, and I think there's no place like bariatrics for this, for nutrition-focused physical exam. And it's really going through somebody, like looking at their nails, looking at their tongue, looking at their eyeballs, and seeing if you can assess for micronutrient deficiencies. Now, this is the supplements, and you probably all know this, but this is based on those 2016 updates, micronutrient updates. This is the current recommendation for supplementation, and I'm pretty sure I gave you charts of it in your handout. But we're saying take a multivitamin, multimineral every day, 1 or 2 a day. Take calcium, and actually calcium carbonate is fine, especially with the sleeve. Calcium citrate better absorbed, especially with the bypass because of the non-acid environment. But we're saying take calcium 2 to 3 times a day. Vitamin D. Now, calcium is from all sources, so you can assess what's in the diet, assess what might be in their multivitamin, and then supplement the difference so that they're getting that 1,200 to 2,400 a day. Same thing with vitamin D. We want iron, and for many of our postmenopausal women or men, the iron in the multivitamin is probably fine, but for menstruating women, they're recommending an extra iron be taken, and B12. So I'm looking at this, I'm going 1 to 2 multivitamins a day, and that multivitamin should contain 100% zinc and 100% copper. And have you ever found a multivitamin yet that has 12 milligrams of thiamine? So you're most likely going to have to do multivitamin plus an extra thiamine, or what they're recommending, a B complex. And then we're saying 1 to 3 times a day, take your calcium, and then take your vitamin D, and then if you're menstruating, take an extra iron, and then take your B12, and we're talking now about 8 supplements minimum. And then we're saying, but don't take your iron with your calcium, because you won't absorb the iron, and don't take your calcium all at once, because you better absorb it if you spread it throughout the day. And then we wonder why our patients might not be able to keep up with the regimen. This is pretty insane. When I saw that paper come out, I was like, you gotta be kidding me, you're adding more supplements. And the reason why I say you gotta be kidding me, because if you really read the paper closely, the evidence isn't very strong. Most of the recommendations are based on C or D. We don't have great data in this field. We don't have great data to base our guidelines on to begin with. So what's really important is that we work individually with patients. We do our own assessment. We look at signs and symptoms. We get a sense of what they can afford, what they can't afford, what's feasible in their life, and help them come up with a regimen that at least they're getting some coverage. Standard supplementation may not be enough, but it's burdensome, it's expensive, and it's very challenging for patient compliance long term. So what I recommend is taking cost, feasibility, practicality. You have a postmenopausal woman, she doesn't need extra iron, she may not even need, she may need more of the calcium, but there's just ways to kind of look at patients individually and maybe make some adjustments to those recommendations. Now, deficiencies increase over time, but as we talked about, we don't see our patients for the rest of their lives typically. They're not coming back every single year. So my recommendation, take this chart I gave you, put it in all your patient education packets, make sure every patient gives it to their primary care doctor, or you fax it to their primary care doctor. Most patients see their primary care doctor every year, And this is the chart. Now, this chart was from the 2013 update, the ASMBS, TOS, Endocrine Society update paper. I took that chart, then I took the new ASMBS guidelines, and then made a new chart of what labs should be tested every single year. You know, when the labs should be tested, and then yearly labs. And all their primary care needs to do is at least see this, because these aren't all standard labs that get done every year. But you have this in your packet. I also gave you in your packet, I wrote a chapter for John Morton. I don't know if you guys know John Morton. He's out at Stanford for his book this January, and I made a bunch of charts. So I actually updated these for you. I gave you the charts so that you can see I added signs and symptoms of each of these nutrient deficiencies, as well as repletion doses for each. So hopefully that'll be helpful, helpful to you, and then the references for that. Okay. All right, so let's go back to Ira. So in 2008, Ira had gained weight. He had lost that weight after we worked on his hypoglycemia, his meal patterns, changed his depression medication. And then he said, I've never been under 300 pounds. That's my new goal. I want to be under 300 pounds. He's maintained this, BMI of 42 for a while. So what did he do? He decided to change his diet. He went vegetarian plus fish, he called it. So I'm a vegetarian plus fish. So he changed his diet. He threw a monkey wrench into that new set point. He joined CrossFit. He changed when he ate. He planned all his meals and snacks, both in work and out of work. He had to prepare more because he was doing this vegetarian diet, and he was perfectly fine with that. He started to self-monitor. We know self-monitoring, #1 tool, even though patients often hate it. He said, to continue my weight loss and maintenance journey, I watch my food intake, I exercise. I know many bypass patients who put all their weight back on. He said, that wasn't going to be me. I'm not doing it. I take one day at a time. If I have a relapse I don't give up. I just get right back to it. And so he's currently, this is Ira now. So this was him last year, 245 pounds, and he reached his goal. He went under 300. Hadn't been 300 pounds since he was in 3rd grade. He told me that when his mom took him to the doctor, he's my age, doctor with a cigarette hanging out of his mouth, because doctors would smoke then, would be yelling at his mother about feeding him, about giving him food and feeding him. And so he started diet pills back then his doctor was prescribing, so that by high school he was, well over 400 pounds. But this is him today. He reached this new goal starting in 2008, and he's still. So the reason I wanted to bring him up is I wanted a good success story, but I also wanted to make the point this was a 12-year journey. Even having gastric bypass didn't make this all happen for him. This has been a 12-year journey. So obesity is chronic. We're not curing it, not even with surgery, and we're constantly going to need to revisit. And of course, the Achilles heel in all of this is maintenance, keeping our patients connected. Okay, so that's the end of my formal talk. But I also wanted to bring your attention to the New England Society of Metabolic and Bariatric Surgery. So this is a brand new chapter started by Matt Hutter at MGH. It's the regional chapter of the ASMBS. And I'm going to turn the page here because I've been asking him to give me a slide to share with you, and he didn't. So I made this last night, and then today he sent me the information. So if you're interested in joining, and guys, we need dietitians at the table. We need dietitians at the table. The reason I'm so active in the weight management practice group in the ASMBS is because we need a voice. This is really a pioneer field, this field of obesity. It's definitely a pioneer field. Now, we don't want to be left in the trenches like we were with Medicare back in the 1940s. We weren't at the table, and we've been fighting ever since for coverage. We really need to be at the table, so if you can, I highly recommend that you get involved in this. You can email them, nesmbs@gmail.com. They can send you an application, or you can send them your information, your name, your address. It is $100, $50 for a one-time joining, and then it'll be $50 a year. So the first to join is $100. They held a conference a few weeks ago. I wasn't able to be there. I think there was a couple of people here that were there. I heard it was fabulous. I know it will be, they will be putting on a lot of good things. So if you can join, please, 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 I highly recommend it. Thank you. And then I hope we left enough time for questions. Do we have time for questions? A lot of time? Okay, good. I did good. I took like 10 slides last night because I was so afraid you didn't want to sit for that long.
Thank you, that was fabulous. And thanks for the plug for the New England, the Bariatric Society. They also would like, if you want to bring the word back, they would like to, I was at that conference.
Oh, good.
And we also talked about the need for mental health providers to be involved, particularly to get a little more education and standardization around what we're doing in terms of pre-screening, and also the clinical reviewers. So if you want to bring the message back to your clinical reviewers, they would like
What
to
do
have
you mean by
you as
clinical
well.
review? Oh, they want the clinical reviewers to get involved. Yes, they're
Yes.
looking for membership, the psychologist,
Yeah,
clinical
but
reviewers.
they'd like to have those individual pieces represented.
So share with your team that you're working with. I'm sorry?
I was just saying, do you have to be recommended to join or?
You
like
do
your
not
letter?
have, do not have to be recommended. Like ASMBS, you have to have like it's so crazy. They need to get rid of that. But no, you can just join. If you need a recommendation, tell them I recommend it. No. I just joined myself.
Wonderful presentation.
Oh, thank you.
I'm curious about your thoughts on weight loss medications in weight loss surgery programs. And also, you know, some of these medications have a defined period of time for use. And as you're saying, obesity is chronic. And if you're going to do something, you need to do it lifelong. What's your thoughts on that?
Well, so it's a really good point because pharmacotherapy only works if you take it. So if you're taking a medication for weight loss, let's say it's phentermine, and somebody's doing really well with phentermine, and it's 6 months, and this typically happens, the primary care, if they're prescribing it, goes, oh, I'm not comfortable keeping you on this that long. Or the patient goes, hey, I'm doing really well, why do I need this anymore? Well, you need it because it's working. And when you stop, it's like nobody goes off their insulin because their blood sugar's good one day. It's good because you're taking your insulin. So it's the same thing with the pharmacotherapy drugs. Now, it's a big issue because we don't have a lot of tools in that toolbox. I mean, if you have hypertension, your doc has like 100 meds to choose from. You have obesity, and there's like 6 approved medications. And so a lot of obesity medicine, you guys are familiar with obesity medicine physicians, right? The American Medical Association has a board certification in obesity medicine for physicians. And so if the PCP is not comfortable, I'd probably try to find an obesity medicine physician who is comfortable. A lot of them are using a lot of meds off-label because the other issue with the pharmacotherapy drugs is they're not all covered by insurance. So some of them can be very expensive, but some of them are combinations of other meds, Topamax plus phentermine. So they can be prescribed separately and maybe even be covered, but they need to be used long-term. They don't work unless you use them. And there is some studies like with phentermine, for instance, where it's used intermittently. But they are used, and as long as you say it's off-label, as long as you say you've got to use this long-term, it's okay to prescribe those. The studies aren't real long-term, but they can be used long-term. I can't hear you. It's okay, sorry, just shout.
Surgery?
Yes.
Okay. They didn't need to come off of them.
Oh no, they will come off of them. Just for the surgery, they may need to go back on them later, I guess, to see how it goes. But yeah, they don't stay on them for the surgery. Much medication as you can get somebody off of for surgery.
But if
Sometimes patients go on medications to, I don't know how common that is, but to lower their risk of surgery.
This might be an odd question, but so with the gastric bypass and the transecting of the vagus nerve, are there surgeons who perform a gastric bypass without transecting?
I don't think you can.
Okay.
Because you're making a new pouch, so you have to transect it.
See, yeah, I said that to my surgeon. He said, well, I don't know if that's a theory because this and this and this. And he said some surgeons don't actually transect that vagus nerve. So I'm going to follow up on that.
How do you make a pouch?
I don't know. I thought it
Because
was
you think of this vagus nerve is preserved in the sleeve primarily because it comes down this part of the stomach, and then there's like branches that go out, right?
Right.
So this part may be cut, but I don't know how they can do that.
no.
I don't
Okay.
know how far up it goes. Anybody else know? Oh, she's saying that you can regenerate as well.
Oh.
So many branches.
Yeah.
Yeah. Yeah, it doesn't make sense that you can't.
Yeah.
The point there is that the studies looking at Ghrelin post bypass are very variable. They're not reproducible. So what else is going on? And so the suggestion is that just by transecting it, even if Ghrelin's produced, it has less of the hunger effect.
And the mice surgeries, are they done laparoscopically or open?
What was that?
The mice surgeries, are they they're doing
Night
those?
surgeries? I can't, what?
Mice.
Oh, the mice, isn't that amazing? The first time I saw that, I was amazed. These tiny little things. And you should have seen the surgeon in the lab doing it. This huge guy. Am I shouting? I mean, I was like, how do you do that? Oh, these. Open. Open. Yeah, that's pretty amazing. But that's, that's where you can't, it's hard to do trials on, like surgical trials on real humans.
Hi, Sue. I have two questions for you. First, I get a ton of
I'm
questions
sorry,
about.
but I allow one per person.
All right, I'll try to mesh them into one question. I get a lot of questions about stretching the pouch and how much physiologically can that pouch be stretched after surgery.
Can I refer you to a great video? And his name is Matthew Weiner, Weiner. He's a surgeon. He does these YouTube videos, and he has one on stretching the pouch that every patient should see it. It'll answer all their questions. It'll make you feel like, oh my God, I don't have to answer this one more time. Because basically there's not a heck of a lot of stretchability. And, if you're gonna stretch back to its original size, very unlikely. And even some amount of stretching doesn't seem to have a big impact on significant weight gain. But that video will answer your questions better than I can.
And the other question was about how soon to take pills afterward.
How soon to take them? We used to have them start the day they go home. The vitamins?
Swallowable pills, tablets versus
swallowing
chews.
pills. It's probably different for the bypass and the sleeve because, you want the pill to dissolve, right? So with the bypass, if it's not going to dissolve and, before it can get absorbed, then, that's why you want to do chewable. It's just so much more absorbable. With the sleeve, you got acid in the stomach, so it might break it down faster. But we usually recommend, and this is really, I make some of this stuff up, but we usually recommend, wait with the bypass, wait 3 months, and with the sleeve, probably in a month, you might be okay. But I totally made that up. I don't know if we don't. A lot of it is just the dissolvability and the absorbability. Evidence by Stu Cummings. Don't you feel though if you've done this long enough, things start coming to you. You kind of see patterns and you kind of.
We see sometimes that our patients after surgery are getting really dizzy and they don't have any history of blood pressure conditions.
They're taking what?
They're getting dizzy.
Oh, dizzy, yeah.
So our surgeon has started micromanaging sodium intake almost to the point where he tries to give them next to none. And then the dietitians sneak it back in and the
If they're getting
dizziness
dizzy,
goes
don't
away.
you want more sodium?
Yeah, he puts them on really low sodium diets, especially if they're retaining any sort of fluid based on our scale.
Wait,
So
he's giving them low sodium because he doesn't want them to get dizzy? Isn't that the opposite?
He's looking at what's in the shakes and milk and things like that.
Wow. This is sort of a tough topic. We
Yeah.
actually do a little role play in our new certificate course on basically the surgeon, the dietitian walks in and the surgeon goes, she goes, excuse me, I was just talking to a patient and you said, the patient told me they could never have fruit again. So it's like, yeah, well, of course they can't have fruit again, it's carbohydrated. And he's like, and it's sort of, we tend to run into these issues, right? And so how do you address that? And the best thing
because he's looking at the scale that shows maybe a 1 to 2 pound shift in water mass.
And then he's thinking that if he adjusts their sodium, he's going to adjust the scale because he's going to adjust whether they pee or they don't pee or they. And that makes sense how. So that's, it comes back to how do I address these issues? So I think I would either find literature that you can bring to him and say, hey, I was reading this, what do you think about it? That kind of contradicts what he's saying. Or say, can we talk a little bit more about your philosophy around this? Because my understanding is, and have a conversation. Now have the conversation, and it's not always easy, especially if that's the person holding your paycheck. Surgeons are a little more difficult than, say, maybe some other medical docs to work with, but the best you can do is, bring the issues up and in a way that you can get at the facts, not dissing him, I guess, or her. But it's a tough one. Do you have surgeons? Anybody have surgeons that, like no fruit or no snacks or no? Like, in what year was your nutrition degree? I didn't realize. Sorry. Any other questions? This was great fun. Thank you so much. I appreciate it. I will send the PDF of the slides for you and that information to Shannon, and then they can post it for you.